Good evening and welcome to another episode of Innovation on the Loose, streaming from the DeBakey CV Education studios here at Houston Methodist Hospital. Now, patching in live from the Seattle region, we have the CEO and COO of Dopl Technologies, Dr. Ryan James and Dr. Steve Seslar. Now, Dopl Technologies is a data and AI company democratizing access to diagnostic exams and interventional procedures. And they're here today to explain more. So I'm going to turn it over to Ryan and Steve, and I'm going to ask the three big important parts. Who are you? What are you doing? And why are you doing it?
Hi, everyone. I'm Ryan James. I'm the CEO of Dopl. We couldn't be more excited to be here. I'll just introduce myself really quickly and then pass it over to Dr. Seslar. Just in terms of my motivation, I grew up in Kalamazoo, Michigan, which used to be a city with one of the highest Black infant mortality rates in the nation. And my dad, who's a OB-GYN, moved us there from Houston, Texas, all the way up to Kalamazoo to change things. And so he led these community-wide efforts that brought care into Black communities, which resulted in Kalamazoo having one of the lowest Black infant mortality rates in the nation. And just watching him do that work very clearly demonstrated to me that healthcare outcomes aren't about what you look like. They're not about your gender or where you live. They're about the systems around you that do or do not help you. And that lesson always stuck with me. And so I was much more interested in technology, though, than becoming a physician. And so I got a degree in computer science from the University of Michigan, worked at Microsoft and NVIDIA, and did a PhD at the University of Washington, where I met Dr. Seslar and our third co-founder, Dr. Monsky. And they brought a new angle into the problem that I was really passionate about. And we all got together and formed Dopl. So I'll kick it over to Dr. Seslar to talk about his motivation, and then we'll dive into our company.
Thank you. Yeah, it's great to be here. I guess for me, this story begins in 2015. And really similar to Ryan, from a personal standpoint, I'm the only doctor in my family, and my parents, as they started to age, I started to see their challenges. They live in a very small rural community in the northeast corner of Vermont, and as you get older, your healthcare needs change, and they reached out to me to help. And I honestly never realized what a challenge it is to get care in rural communities. And as I thought more about it, as a specialist who's always worked in urban and large areas, I realized I was part of the problem and I wanted to be part of the solution. And so I met Ryan in 2017, and we realized that we were on a shared mission to bring access to more specialized care that's generally not available in rural communities to these under-resourced areas.
That's great. Well, I really do appreciate the background. So we'd love to hear what your technology is. What are you guys working on?
Okay, fantastic. I just want to quickly shout out our third co-founder, Dr. Wayne Monsky. He's an interventional radiologist who treats patients, for example, trauma patients who are life flighted to him, bleeding out on a helicopter. And so everything we're about is getting care to patients faster to improve outcomes. And our approach to this is to, over time, decrease the skill that's required to perform exams and procedures so that we can democratize care for everyone. And in our first version of this, which Dr. Seslar will talk about in detail, we are performing in-person exams in rural hospitals by sending sonographers out to these locations to perform in-person exams. And it's inefficient, it's costly, but we're taking care of patients and we're learning a ton about the problem. In the second version of this, which I'll go into detail about, we're performing remote ultrasound exams. And so now the sonographer can work from home or from a scan center, which adds really important flexibility to their schedule and improves efficiency. And has a bunch of other great benefits as well, in that we can now treat more patients and they can get care faster. And then in the third version of this, through the data that we collect from the remote ultrasound exams, we'll train our algorithms and be able to perform autonomous ultrasound exams to augment the specialist skill set, so they can perform more procedures faster, so that we can treat more patients. And this is when we truly democratize access. And then finally, we'll get back to our roots, and be able to not only do remote and autonomous ultrasound exams, but remote and autonomous interventional procedures, like those that Dr. Seslar and Dr. Monsky perform today. And so with that, I'll kick it over to Dr. Seslar to talk about our V1.
Yeah, so we went out to rural hospitals and we recognized very quickly that patients with heart conditions who required care was a big problem, and in particular, heart failure. And just to give the audience some context, heart failure is a huge problem in America in general. Over 6.5 million people in the US suffer from heart failure today. A staggering number of new cases come in each year. And the survival over 10 years is not very good. We all have about a 1 in 4 lifetime risk of developing heart failure. But as sobering as these statistics are, when we move out into rural areas, the story gets even more concerning. And so if we look at the disparity between the care that happens in urban settings and that happens in rural settings, across the board, it's worse in rural areas. They actually have a higher prevalence of heart disease and the risk factors that cause it. They're, in some cases, significantly more prone to hospitalizations. In other studies, actually, they were less likely to be hospitalized because they didn't have access to a local hospital. In all cases, the mortality rates in rural areas are substantially higher than they are in urban areas. And so we went and talked to the providers out there. Next slide. Oh, and sorry, beyond heart failure, there's a whole host of things that echocardiography or ultrasound imaging helps in terms of managing these various heart conditions. Everything from arrhythmias to congenital heart disease to aortic stenosis can all be facilitated with cardiac ultrasound. Next slide. And so what we learned when we went out to these hospitals is they basically couldn't do a cardiac ultrasound, not because they didn't have the machine and certainly had the patients. They didn't have the sonographer, the ultrasound technician. And so they had to refer every patient out. And this was a typical story. The wait time, 3 to 6 months. Very difficult to provide adequate care with that kind of resource limitation. And so we said, you know what, we're not gonna wait. We're not gonna wait until we have our technology built. We're gonna go out and start learning how we can help today. Next slide. And so we did. We got 4 rural hospitals in Washington State to sign up for what we call boots on the ground. These are conventional outreach sonographer services, and we drive and support and pay the sonographers to go out and perform studies at these centers today. As Ryan said, while it's very gratifying, it's also very inefficient and unscalable. But this is what version 1 looks like. And not only have we learned about the need in terms of ultrasound, but all the things that go into providing care around that. So whether it's bringing in an ultrasound machine for hospitals that don't have it, setting up the PACS system so the images can be exported out for a reader, setting up the EMR, all the things that come along with providing a new service line. Next slide. And so here we are. This is at Whitby Health, the first hospital we implemented in, and that's our sonographer, Danielle, who goes out there to this day. The day we are ready to do V2, then she'll be able to stay home and do scans from there. But today she drives out there every week to perform ultrasounds. Next slide. And it's back to you.
And so I'll detail sort of what our next version looks like and the progress we've made there so that we can get our sonographers out of the room and into the comfort of their own homes or at the expert site so that we can treat patients faster and just give everyone a better, more convenient type of care delivery. This is what our remote ultrasound system looks like at a high level. It consists of a patient site and an expert site. And at the patient site, we give the patient a safety button. And when they press that, the robotic arm goes limp. And so it gives the patient a level of control. The robot arm is holding a off-the-shelf sort of third-party FDA-cleared ultrasound probe. Dopl prints a probe holder that attaches it to the robot, and that gives the remote sonographer full control as they're scanning. There's a medical assistant in the room who makes the patient feel comfortable, preps the patient, puts gel on the patient, at least in this initial version. And there's also a user interface that displays the remote sonographer providing a line of communication to the patient and the medical assistant. Then on the expert side, there's the expert side user interface, which has the ultrasound image, as well as the whole ultrasound user interface, in addition to an image of the exam room, so that the sonographer has communication with the medical assistant and the patient. There's also a controller. This looks and feels like a standard ultrasound controller, something Dr. Seslar has one of the many things that Dr. Seslar and Dr. Monsky bring to the team is a deep understanding of the clinical workflow and how to perform exams and procedures. And so Dr. Seslar has designed this to be exactly like it is as if you're in person to decrease the learning curve. There's also the sonographer, of course, who is now, instead of being located at the patient site, scanning the patient in person, they can provide their care remotely. And so this is the general architecture of our remote robotic ultrasound system. And I'll show you a video. We took this video earlier this year with a prototype version of our system. And I'll play this video so you can see the different steps. So this is our system that brings remote care to rural community hospitals. Effectively, it gives the sonographer full control by having the robotic arm mimic the sonographer's hand movements. And during this exam, the patient was located on Whidbey Island, Whidbey Health on Whidbey Island. At the start of the exam, the medical assistant applies gel to the patient's chest and then moves the robot arm to the patient. Dr. Seslar was in Bellevue, about 50 miles away, and he initialized a connection to the robotic arm using the expert site user interface. And then he was given a picture of the patient site with the robotic arm, the MA, and an ultrasound machine. And then he used the ultrasound images in his controller to then manipulate the robot to acquire diagnostic images on the patient, who in this case was a healthy volunteer, which was me, during this exam. The system also supports multiple different scanning angles, because it's not just, up, down. During an echocardiography exam, during other exams, the patient is in multiple different angles, and our robot arm has the same, if not more, degrees of freedom than the human wrist, and so we can get in all the same angles that a sonographer could, as if they were in the same room. And so just to highlight some of our progress to date, we've done over 50 scans with multiple clinicians who have done scans on phantoms and on humans. We also received IRB approval to do scans on humans. We've evaluated multiple applications, both in cardiac vascular and in abdominal pelvic. We've done a lot of network and reliability testing. We've got a relationship with T-Mobile, and so we've done a lot of testing over 5G, validating our bandwidth and latency thresholds. We're seeing about 2.5 megabytes per second in download and upload, as well as about a 250 millisecond latency threshold. When we're under that, we see that the operator is comfortable. If we exceed that, it starts to get a little bit uncomfortable. And so overall, the tests we've done from here to really all across the US, we've seen that we fall well within those thresholds. We've also done a scan from Seattle to Norway, and we started to exceed the threshold during that scan. And so we think that national scans across the nation are feasible. We also think that international scans will be feasible, especially as we progress our technology to accommodate for some of the limitations around distance. And then we've gotten some great feedback from sonographers. We've done multiple usability studies, and folks, their first impression is generally very positive. And we've also recorded some of the feedback that we're going to implement into the next version of our system. And so just to give you a sense of a roadmap on where we are today and where we're going, we're currently refining actually, let's just say V2. We're refining the remote robotic ultrasound system beta version, and then we're expecting FDA 510K clearance at the end of next year, end of 2025. And then early 2026, we'll flip those 4 customers that Dr. Seslar was referring to, our boots on the ground customers. We'll flip them from in-person ultrasound exams to remote robotic ultrasound exams, and then start to scale up and collect data in preparation for including more AI to augment the sonographers' exams. And so we couldn't be more excited about this. Thank you for listening, and we'd love to hop into the Q&A and answer any questions.
Ryan, Steve, thanks for that. It was a really insightful presentation there, and I've got a few questions. So, you're talking about heart and vascular scans. So what are the top 3 scans that you're focusing on? I'm assuming you're going after high volume scans, but what type of scans in particular?
Yeah, so we really based this decision largely on the need we've identified. So we've spent, the better part of the last 5 years in contact with a variety of rural hospitals, not just in Washington State, but across the country. And the consistent refrain that we hear is that cardiac ultrasound is the biggest challenge because it's the biggest number of patients, and the sonographers are specialized enough that it is hard to get them in any one small rural hospital. So cardiac is our number one focus going out. I would say the second thing that we hear a lot of is obstetrics. And so it's obviously a much smaller population, but the need is huge. And particularly in rural areas, what we're seeing is we're losing obstetric centers in rural community hospitals. And so we'd like to help support keeping that care local. And then finally, when we talk in the emergency room, they're also very interested in abdominal to look for gallbladder disease, and vascular looking for blood clots like in the legs and things like that. These are critical, urgent diagnoses that need to be made in a timely fashion. And sorry, one more, in pediatrics, we're looking into the diagnosis of appendicitis, also urgent, and something that isn't done well in community hospitals.
Got it. So going deep into your tech, now obviously we've got a good understanding of the system as a whole, but I'm seeing that the robotic arm, for example, it's an off-the-shelf robotic system with an off-the-shelf FDA-approved ultrasound transducer. So what is the actual heart of your technology? Where does Dopl live in the kind of IP space, etc.?
Yeah, so we have one patent that was issued by the USPTO that covers how we collect data, how we transmit data, and how we use that data to train AI. So the heart of our IP is a software platform for connecting third-party devices and transmitting data between them. Another thing that we're finding is that there's this novel interaction between a remote specialist and the technology on the other end, and so we're learning a lot of sort of unique human-computer interaction mechanics that we intend to patent over time as well. So we've got a few other patents in the pipeline that we're working towards as well.
Got it.
And just to follow on that, it's something that, there are a few, this is a nascent, rising field. We are not the first people to think of telerobotic ultrasound. But what we've noticed is, from the company in Sweden to the folks in France, they really have fundamentally altered the sonographer ultrasound tech experience in ways that I think are detrimental to their ability to actively or accurately perform the scans. And so we're trying to take it back to what can we do to make this the most native experience for the sonographers, and that, as Ryan said, has opened up some real new insights into this.
Got it. And I guess my last question is kind of got a couple of things merged together. So you talked about IRB approval, right? Now I'm thinking geographical distances, and on top of that I'm thinking legal issues. Right, so you're in Seattle, you want to operate in someone here in Houston. If you get IRB, you got to have it, I'm assuming, at both institutes. But what else do you need from a legal standpoint to allow that to occur? Because I think that's the trouble that a lot of people, with all these remote and virtual platforms, I think that's the kind of bottleneck that they're hitting.
Yeah, so ultrasound is a great first application for telerobotics for a whole host of reasons. But one of those reasons is that the licensure and credentialing of sonographers is not confined to state lines. So when you get certified as a sonographer, you're certified nationwide. And so we will have and will be able to credential remote sonographers from any state, any part of the United States to perform services in any other part of the United States without changing any existing laws. And then really beyond that, the rest of the operation, the rest of the diagnostic procedure all happens the way that it happens today. So what we basically facilitate is image acquisition. Once those images are acquired, they're stored locally on the ultrasound machine as the sonographer is recording them, and then they get exported to a PACS system just as if the sonographer was in the room. And so the billing, the coding, the read, all of those things will happen in the same way that they happen today. Those aren't the limiting reagent. The limiting reagent has been the availability of the sonographer, and that we can do today nationwide.
So that's a really good point there. So if they're coding, if they're putting in a CPT code, are they coding for virtual services or on-site services? And are there CPT codes to cover what you guys are doing?
Yeah, right. So, of course, now we're all talking about post-commercialization, post-FDA clearance. But because we're not fundamentally changing the outcome of the study, in fact, the whole purpose of going through the FDA is demonstrating substantial equivalence between the two. And because the presence of a robot in general has not been felt to indicate the need for a new code, we're going to use existing ultrasound codes that are available today. And I'll just give you an example from the surgical world. If I do an operation, or if I do one of my electrophysiology procedures with a stereotaxis machine, we don't code it any differently. It's still coded as an electrophysiology study. Same will be true for ultrasounds. It may be true in the future we might pursue a unique code, particularly as Ryan has been talking about incorporating automation into the process. Then I think it might be very interesting to explore new codes. But initially, we're going to go out using the same codes that are used today.
Wonderful. Well, on that note, I'd just like to thank you both again for patching in. I really do appreciate it. And to my audience, thank you for your time. If there's anyone out there that's interested in connecting with Dopl Technologies, I believe their information was put on the presentation and we will make it available in the description. Or you can actually reach out to myself. I'm happy to connect you all. And thank you very much. See you again soon.